Tim?
Yeah. Hi, Dr. Ferrer.
Hi, I'm good to go.
Okay. All right, well, good afternoon, everybody, and thank you for joining us today for this media briefing from Public Health. We'll use the same format as always. Dr. Ferrer will make a few remarks, give some updates. We will then take your questions, and that'll be followed by remarks in Spanish that will begin probably right around 4 o'clock. So with that, Dr. Ferrer, I'll turn things over to you.
Yeah, thanks so much, Tim, and thank you everyone for joining me for today's briefing. This afternoon, I'll be talking about case, hospitalization, and death trends by vaccination status, stratified by race and ethnicity and age group. I'll also provide an update on our variant data. We'll review our progress with vaccinations, including geographically, and we'll share the latest data on cases, outbreaks, and vaccinations in schools and among school-age children and staff. I'll also share information on vaccine efficacy and our plans to provide eligible residents and workers with their boosters. First slide. I'm sad to report 32 additional deaths today. At least 27 of the people who passed away had underlying health conditions, and this brings the total number of deaths to 25,942 across the county. We extend our deepest condolences to everyone who's grieving the loss of a loved one, a friend, or a coworker, and I'm keeping you in my thoughts and my prayers. We're reporting 1,900 new cases today, bringing the total number of cases in LA County to 1,449,923. To date, more than 8.5 million people have been tested and had test results reported in LA County. And our daily test positivity rate is now 1.5%, a small decrease from last week's same day rate of 1.6%. Our daily average case rate with what we call a 3-day lag is now 12.3 cases, new cases per 100,000 people. That's a decrease from last week's 3-day lagged case rate of 15 new cases per 100,000 people. There are 991 people currently hospitalized with COVID-19, and this is a decrease of 165 people over the past week. We're relieved that hospitalizations have dropped below 1,000 for the first time since July. There are currently 205 open investigations at residential congregate settings and non-residential settings where there's at least one confirmed case of COVID-19. Next slide. In order to assess the risk of COVID in LA County, we do use the CDC indicators and thresholds to categorize community transmission of the virus. You'll note that this framework uses a cumulative 7-day case rate, meaning the number of new cases per 100,000 people over the past week, rather than a daily case rate, which is what we usually talk about. Transmission in LA County has decreased to the substantial level, with our 7-day cumulative case rate now at about 86 new cases per 100,000 residents. Again, this is reflecting our trend of decreasing cases over the past few weeks. Next slide. This graph shows trends in cases, hospitalizations, and deaths in our county from the beginning of the pandemic through September 15th of this year. Note that the data is based on episode dates, and it lags behind the information that we're using to calculate our daily case rates. Overall, we continue to see a downward trend in cases, hospitalizations, and now deaths. And while the data here stops on September 15th, reported data since then continue to trend downward, providing some reassurance that higher vaccination rates and safety precautions at Labor Day celebrations help divert the usual increase in cases we experience after major holidays. On September 15th, our 7-day case average was 1,476, and that's the lowest it's been since July 14th. Meanwhile, hospitalizations declined 17% over the last week's numbers, and after a long plateau, deaths have also begun to decline. Nevertheless, as of September 15th, we're still seeing almost 24 deaths every day, and these preventable losses are no less painful for being smaller in number. Next slide. We continue to track outcomes among fully vaccinated people to understand the effectiveness of our vaccines. And this slide shows the numbers for cases, hospitalizations, and deaths among fully vaccinated in a scaled diagram. The large green box represents the more than 5.4 million residents who are now fully vaccinated. The tiny purple box in the left lower corner of this green box represents the 52,140 fully vaccinated people who tested positive for COVID as of September 21st. You can note that this is a larger jump than usual in 1 week. And this is because this week we're including about 1,800 presumed reinfections that occurred between May 1st and September 18th as part of these calculations. In the past, these cases were not included because it wasn't clear whether these cases represented new infections. But now the accepted definition includes reinfections that occur at least 90 days after a prior infection. And so we're adding those numbers both here and to our case counts. In all, still less than 1% or 0.9% of fully vaccinated people in LA County have tested positive. Of those who tested positive, 1,732 were hospitalized, and that's up from 1,359 the week prior. This translates to 0.03% of all fully vaccinated people ending up hospitalized. Deaths in this group over this interval also increased slightly, from 199 deaths to 229. This translates to 0.004% of fully vaccinated people passing away. In these small increases, we see the reality that the vaccines do not provide 100% protection. As more fully vaccinated people are exposed to the virus, more fully vaccinated people are likely to get infected. However, what we also see clearly in these numbers week after week is the fact that fully vaccinated people continue to be extraordinarily well protected from hospitalization, and they're very unlikely to pass away from COVID. Next slide. Delta continues to predominate among the specimens that are sequenced by our public health lab and the labs that are reporting to us, comprising 100% of all variants recently identified among those specimens. Although CDC does not consider mu or lambda variants to be variants of concern, the World Health Organization does identify them as variants of interest due to their involvement with significant community transmission of multiple COVID-19 clusters in multiple countries. And so we continue to gather data on the distribution of these variants among both new and historic samples. This week, we're reporting 10 mu variants were newly identified from samples that were previously taken from LA County residents. And that now means that there's been a total of 250 cases linked to mu variants. Only 5 of these mu cases that have been identified were from after August 15th of this year. And again, as you can see, Delta is crowding out both the mu variant and the Lambda variant. We didn't identify any new Lambda variants in the past week, leaving our total number of Lambda cases stable at 28. We'll continue to provide regular updates on variant trends among LA County residents. Next slide. I'm now going to show you several slides displaying outcomes by vaccination status that are divided by race and ethnicity as well as age groups. And this now includes pediatric age groups as well. In all these slides, unvaccinated groups are represented by dotted lines, while vaccinated groups are represented by solid lines. The first slide shows that case rates continue to decline among all unvaccinated and vaccinated racial and ethnic groups, with the highest rates of cases still among Latinx and Black unvaccinated residents. That's indicated by the gray and blue dotted lines. Next slide. If we look at cases by age group, we see the highest case rates are now among unvaccinated teens, ages 12 to 17, represented by that dotted turquoise line, while vaccinated members of the same age group have the lowest case rates, indicating that the vaccine is extremely protective from infection among our teens. The second highest case rates are among unvaccinated young adults aged 18 to 49, and you see that in the dotted purple line, and unvaccinated adults aged 15 and older, which is in the dotted yellow line. Of all the unvaccinated groups, the lowest case rates are among children 0 to 11, which you can see in the green dotted line. Because this age group remains ineligible for the vaccine, they are all, of course, in this group of unvaccinated young people. You'll note that the case rate among unvaccinated 12 to 17-year-olds peaked in the middle of August, and this was around the time that most of LA County school districts were reopening. Since then, case rates in this group did decrease. They're still the highest, but they have decreased, and that follows the trends that we're seeing in adult populations. But it does affirm that school is indeed a relatively safe place for children of this age. Next slide. Looking now at hospitalization rates by race and ethnicity, we see an overall decline in hospitalizations among all unvaccinated groups, with hospitalizations still highest among unvaccinated Black residents, represented by the dotted blue line, followed by white and Latinx residents, represented by the dotted red and gray lines, respectively, which are about the same. While hospitalization rates remain much lower among vaccinated individuals of all racial and ethnic groups, the vaccinated residents most likely to be hospitalized are Black residents, represented here by the solid blue line. They're 3 times less likely to be hospitalized than their unvaccinated counterparts, but as you can see, they're more likely than other vaccinated residents to end up being hospitalized. A long history of inadequate access to the essential resources that support optimal health has resulted in Black residents across LA County and the country experiencing higher rates of disease that, as we know, put them at elevated risk for severe COVID illness. Our trend lines validate this deplorable reality, which continues to contribute to the higher rates of hospitalizations and deaths from COVID experienced by our Black residents. Next slide. There does remain much variability by age groups on experiencing serious illness from COVID. On this slide, which shows hospitalization rates by age groups, we see that while hospitalizations are declining among unvaccinated adults over 50, represented here by the dotted yellow line, this group still remains at highest risk for hospitalizations, followed by unvaccinated adults 18 to 49, represented by the dotted purple line. Meanwhile, hospitalization is so unlikely among vaccinated adults and children and teens that the trend lines representing them nearly blend together at the very bottom of this chart. Next slide. We do present data about deaths with a 3-week lag to account for some of the delays in receiving reports of deaths. As you can see, in early September, deaths among unvaccinated residents across racial and ethnic groups had plateaued, while death rates among vaccinated people remained low. Notably, this is the 2nd week in a row that we're seeing the highest death rates in unvaccinated white residents, represented here by the dotted red line. In the past, we've generally seen deaths due to COVID decline 5 to 6 weeks after case rates, when our case rates, as you know, peaked in late July in Black residents and early to mid-August in other groups of residents. We therefore anticipate our death rates may remain elevated among unvaccinated Latinx, white, and Asian residents through until the end of September. Next slide. Because deaths are so few and far between among children, we're only presenting adult death rates on this graph. As you can see, unvaccinated adults over 50, represented by the dotted yellow line, are at the highest risk for death, with the risk 18 times that of their vaccinated counterparts in the solid yellow line. Next slide. With cases, hospitalizations, and deaths now receding, we remain focused on driving up our vaccination coverage to avoid continued cycles of surges. As of September 19th, 92% of LA County residents 65 and over have received at least 1 dose of the vaccine, as have 78% of residents 16 and over, 77% of residents 12 and over. 68% of residents 12 and over have been fully vaccinated. 66% of LA County teens between the ages of 12 and 17 received at least 1 dose, and 57% of our teens are now fully vaccinated. Out of all of our nearly 10.3 million LA County residents, including those who are not yet eligible for the vaccine, 66% have received at least 1 dose, and 59% are fully vaccinated. Countywide, more than 80,000 third doses have been administered by LA County providers to those who are in fact immunocompromised and have come in to get their third dose. Next slide. Although we have a long way to go before our entire community is vaccinated, I don't want us to lose sight of how far we came over the course of this past summer. On the left side of the slide, you see a map of LA County at the beginning of the summer, showing the percent of people vaccinated in cities and communities countywide. The darkest green shading represents communities where 75% or more have received at least one dose of the vaccine, while the darkest brown shading represents communities where 15% or fewer have been vaccinated. The areas that are circled in red are where we've seen the most dramatic increases in vaccination rates through September 19th, and they include communities in the southern, eastern, and northeastern part of the county, where enormous progress has been made increasing vaccination coverage. And while we're pleased with the progress and we're grateful for these efforts to improve access to vaccines, there are areas where our rates are still well below where they need to be, particularly in the northern part of the county. Next slide. And I show you this slide every week, and unfortunately, very little has changed this past month. This is a slide that shows vaccination coverage by age groups and by race and ethnicity. When these numbers remain low, it's because we simply are not getting enough new people in for first doses of vaccine fast enough, which means we're not increasing our levels of community immunity to where they need to be for us to avoid future surges. Next slide. We do continue to offer vaccinations at more than 1,300 fixed sites countywide and through the deployment of more than 400 mobile vaccination teams each week. Still, as you can see from this graph, the number of people being newly vaccinated each week is actually decreasing. Between September 13th and 19th, we administered about 42,000 doses across the entire county network. And while this number will increase by a few thousand once all reporting is complete, it indicates a sustained slowing in our vaccination progress. Not everyone who's eligible for a vaccine is getting vaccinated. And as we've learned from other settings, when many people in an area are unvaccinated, other public health measures like mask and vaccine requirements become particularly important in reducing the worst outcomes of COVID infection and the increased probability of new variants of concern. Next slide. And while we aren't where we need to be as we head into the fall and the winter, the progress that has been made reducing community transmission has in fact impacted transmission at schools, because lower community transmission is correlated directly with fewer cases showing up at schools. In the next few slides, I'll present some information from our K-12 schools. I do want to note that hopefully by the end of the day tomorrow, or at the latest Monday morning, the school dashboard with interactive maps and summary tables should be live, and it'll be linked with all of our other dashboards. And you can find that in the drop-down menu on our data page, which is http://www.ph.laccounty.gov/media/coronavirus/data. So we'll be, of course, making sure that everyone has access to that as soon as the data is posted. On this slide, you can see staff and student cases and close contacts represented by trend lines. Most of the cases at schools are diagnosed through routine screening of asymptomatic people, which identifies many infected individuals that would ordinarily not be detected. The lines in shades of pink represent cases, while lines in shades of green, represent close contacts. Darker shades represent student data, while the lighter shades represent data from the staff. Please note, can you guys go back? Thanks. Please note that because the numbers of student close contacts are so much higher than all the other metrics on this slide, they're plotted on a different y-axis that you can see to the right of the slide. As schools opened in August, we saw weekly student cases, here represented by the dark pink line, increase from about 1,300 to a peak of nearly 2,800 cases the week that ended August 22nd. The number of student close contacts, represented by the dark green line, These are students who are identified as a close contact with a confirmed case, rose correspondingly to a peak of nearly 11,000 by the end of August. Since then, as you can see, both student cases and contacts have decreased substantially. Last week, we saw a little over 900 student cases and about 5,000 student close contacts. And remember, our student population is about 1.5 million and an additional 200,000 staff and teachers supporting them. Meanwhile, you can also see that staff numbers have also decreased weekly from their high point in mid-August to last week, where we saw only 136 staff cases and 44 close contacts among staff. We do attribute these downward trends to the tremendous work of those at our schools, as well as the work that was done to drive down community transmission. And this includes the administrators, teachers, and staff who have invested a huge amount of energy and care into learning an entirely new way of doing things this year. We're also thankful to the parents, students, and broader school communities that have supported each and every school in implementing multiple safety measures that obviously are working to limit transmission of the virus at schools. Next slide. Most K-12 cases are not associated with outbreaks. However, when 3 or more cases are linked to transmission at schools, we consider these cases to be part of an outbreak, and we dedicate additional resources to investigating and stopping transmission within the school and social networks that are involved. Although our overall case numbers in schools have decreased, our number of outbreaks has risen just ever so slightly, from 8 outbreaks the week ending September 11th to 11 outbreaks the week ending September 18th. This pattern likely indicates having many more schools open for at least 2 weeks now than earlier in the year. Most of our outbreaks continue to be in elementary schools and in school sports, as you can see, although last week we also saw 2 outbreaks in our middle schools. Given that more than 3,000 schools are now open, these numbers remain impressively low. Next slide. This slide illustrates the numbers of cases and close contacts that are linked with the outbreaks that I showed you on this previous slide. You can see that student cases involved in outbreaks, again represented in dark pink, peaked the week ending September 11th. Then last week they decreased by about half. The number of student close contacts related to outbreaks, again represented here in dark green, has fluctuated, but again decreased by nearly half over the past 2 weeks. Staff cases and close contacts linked to outbreaks have generally been in the single digits. While early detection and control of outbreaks results in smaller numbers of involved cases and contacts, I would note that outbreaks taking place in this past week may still be open and under investigation, and therefore the numbers of students and staff affected in the most recent outbreaks represented here can still increase. And obviously, we'll catch this number up next week. The next slide. With so much new information now available about booster doses, I did want to share some data from recent studies about vaccine effectiveness and the rationale for boosters among some individuals in our populations. In the results of a study that was published last week, the CDC indicated that all FDA-approved COVID vaccines provided a very high level of protection against hospitalization for COVID in real-world settings during the surge of the Delta variant. Vaccine efficacy, however, did vary a bit among vaccine brands. Between 2 weeks and 4 months after vaccination, Moderna vaccines reduced COVID hospitalizations by 93%, while vaccine effectiveness against hospitalizations was 88% for Pfizer and 71% for Johnson & Johnson. The chart on the right shows the antibody levels in healthy adult vaccine recipients 2 to 6 weeks after vaccination. As you can see, these antibody levels correspond to the different levels of vaccine effectiveness, with levels highest amongst those receiving Moderna vaccine, represented on the left, slightly lower amongst those receiving Pfizer vaccine in the middle, and still a little bit lower amongst those receiving Johnson & Johnson vaccine. And again, a note of caution that antibodies is just one part of our defense system. There are other parts of our defense system that we're not able to capture with antibody data. The durability of vaccine protection was also assessed after the 4-month mark for for those who received Moderna and Pfizer vaccines. It wasn't assessed among people receiving the Johnson & Johnson vaccines because in this study, the group who had received Johnson & Johnson was much smaller than the other two study groups. After 4 months, Moderna was still highly protective, preventing 92% of hospitalization, while Pfizer's protective effect against hospitalizations had waned a little bit to 77%. Meanwhile, scientists in Israel, where Pfizer is the predominant vaccine given to residents in the country's national health system, they also published data in the New England Journal of Medicine last week, and they detailed results of their booster shot program. Their program, which has prioritized providing booster doses to adults aged 60 and over, showed that as few as 12 days after vaccination, these older adults saw an 11-fold decrease in their infections and a 20-fold decrease in severe illnesses. Next slide. These data, along with information received from Pfizer and other studies, provide the rationale behind the Food and Drug Administration's recommendation yesterday in support of providing third booster doses of Pfizer vaccine to a subset of people that included older adults. Yesterday's recommendation indicated that third doses should be administered at least 6 months after the second of 2 doses of the Pfizer vaccine, and should be offered to adults 65 years of age and over, as well as adults younger than 65 at high risk of severe COVID due to underlying health conditions, and also offered to adults younger than 65 with high institutional or occupational risk. The FDA did not recommend boosters for people below the age of 18 or for people who received doses of our other 2 vaccines, Moderna vaccine or Johnson & Johnson. Today, the CDC's Advisory Committee on Immunization Practices met and voted on who they believe should receive the booster doses. Before I detail the results of their vote, I do want to note that this vote does not constitute the CDC recommendation. We expect the CDC leadership to consider the ACIP's input, and then they'll make an agency recommendation shortly, obviously in the next couple of days. The ACIP voted to recommend that third doses should be administered at least 6 months after the last dose of a 2-dose Pfizer series in adults 65 and over, residents of long-term care facilities, people 50 to 64 with underlying medical conditions, and people 18 to 49 with underlying medical conditions based on individual benefit and risk. Once we receive the CDC agency's directors' recommendations, we'll obviously work with the state and our local partners to ensure that those eligible for boosters are able to get their third dose while prioritizing, as always, continuing to reach those that have not yet gotten their first dose and those that are most at risk for poor outcomes. Next slide. In LA County, slightly over 1 million individuals received 2 doses of Pfizer prior to April 1st. 420,000 of these individuals were 65 and older, and many others were healthcare workers and people with severe risk for serious illness from COVID, because that's how vaccine eligibility was rolled out. We are prepared, once CDC finalizes eligibility guidance, to administer boosters to everyone who needs to get this dose. I do want to answer a few questions we expect that people will have as we prepare to administer booster doses to those who are eligible. While we can't answer all of the questions with certainty yet, because we're still awaiting the CDC guidance, we do anticipate that adults 65 and older and residents of long-term care facilities who received 2 doses of Pfizer prior to April 1st will be eligible, and that people 50 to 64 with underlying medical conditions and some people 18 to 49 with underlying medical conditions are also likely to be eligible if they received their 2 doses of Pfizer prior to April 1st. We also expect to hear from the FDA and the CDC about how, in fact, eligibility will work for other individuals aged 18 to 64 with high institutional or occupational risk. So we know that they were included, as I noted, in the FDA EUA, but they are not yet included in the CDC guidance, and we will wait to get that final guidance from CDC either later today or hopefully tomorrow. The easiest way to plan for your booster, if you fall into one of these 4 certain eligible groups, does not include the last group here, people 18 to 64 with high institutional or occupational risk, but it does include everybody else, is to make an appointment at one of the hundreds of sites that offer Pfizer vaccines. Remember, this is only for people who received 2 doses of Pfizer prior to April 1st. And can now come in if they're in an eligible group to get that 3rd dose. But you'll be able to make an appointment for a booster using the My Turn system, which should, pending again, information from the CDC, which should be ready for booster dose appointments, we're hoping by tomorrow. You can also make an appointment at a pharmacy or a clinic that offers vaccinations. If you want to make an appointment using My Turn, you can click on the button for additional doses. You attest that you're eligible based on the new federal criteria, and then you'd be able to go ahead starting tomorrow and make that appointment. There are also many places that don't require appointments, and you can go to vaccinatelacounty.com to find a community location near you where you can walk in and get your booster if you're eligible. All you'll need to bring with you to get your booster dose is proof that you have received 2 previous Pfizer doses, which for most people will be in the form of a white vaccination card you received when you got those 2 vaccinations. Or you might have a photo of your white card, or you have a digital record of your 2 doses. At many sites, you may be asked to sign an attestation form at the time you get your booster dose, indicating that you meet the criteria to receive this booster. And if you're in an eligible group, but you received a vaccine other than the Pfizer vaccine, it looks like you will need to wait until the FDA reviews the data around the need for and the safety of Moderna and J&J boosters. Next slide. I wish that was easier, but it's a little bit complicated until we get the final recommendation from the CDC. I know that there are many people who see our case rates decreasing alongside of our dropping hospitalization and death rates, and they think we must be getting back to normal now. Why are we still pushing vaccines and living with restrictions like mask requirements and even adding requirements like vaccine mandates, targeted vaccine mandates? These are reasonable questions, and I think it's helpful in responding to these concerns to look at some of the information about what's going on in the rest of the country. This table shows 2-week case rates and mortality rates as of September 18 in 4 parts of the country. Here in LA County, where 59% of our population is fully vaccinated, and as you know, masks are required of almost everyone in indoor settings, and vaccines are mandated for many people. In New York City, where 62% of the population is fully vaccinated, vaccines are mandated at all indoor dining, fitness centers, performance venues, and entertainment venues. And in Texas and Florida, where 51% and 56% of the state's populations have been fully vaccinated, and state leaders have actually moved to ban mask and vaccine requirements in a variety of settings. In the 2 weeks before September 18th, there were 250 to 280 cases for every 100,000 people living in LA County and in New York City. While in Texas and Florida, case rates were about 800 new cases per 100,000 people. It's 3 times higher. And we can also look at the differences in mortality rates. Here and in New York City, we saw 4 and 2 deaths for every 100,000 people, while Texas saw 12 deaths and Florida saw 22 deaths for every 100,000 people. That's 3 to 5-fold the number of deaths that we're seeing in LA County. Different case and death rates aren't just happening to us. They're a product of the collective actions that we're taking. Businesses and people who live in different communities change these numbers when they adopt rules that add layers of protection against a deadly virus. This includes wearing masks, getting tested and vaccinated, and agreeing to live with restrictions that reduce opportunities for transmission in high-risk settings. In places where sensible steps have not been taken to reduce the spread of the virus, the Delta strain continues to ruin futures and take lives at a rapid pace. As I share the data curves every week, I'm mindful that these curves are us, and our individual and collective conduct is making a difference in the directions the curves are taking. The reality is we're not back to normal. There remain too many opportunities for the virus to spread and for new variants of concern to take hold. Our pandemic history has told us that we make our best progress when we actively take steps to reduce the spread of the virus. Until community transmission is low and vaccination coverage is much higher, prevention strategies remain essential to our collective well-being and our economic recovery. Waiting until spread is high, super high again before acting doesn't reflect the reality of this pandemic and the destructive potential of the virus. We need to use the tools we have to effectively reduce the risk of transmission and keep each other healthy and safe. Thank you, and now I'll take your questions.
And if you'd like to ask Dr. Furr a question, please click on the hand icon, which is in the participant panel, or you can send me a message through our chat and I can manually add you. Our first question will go to Ron Lynn with the LA Times.
Hi, Dr. Furr. Thanks so much for taking our questions. We have questions today on mass vaccination sites, hospitalization rates among Black residents, and the flu. First, as we get ready for a season of boosters, do you anticipate reestablishing or expanding vaccine mega points of distribution like we saw in the first rollout of the vaccines, either for boosters or pediatric vaccinations? Second, the data was indeed troubling that you just showed involving the hospitalization rates among vaccinated Black people being higher than for other racial and ethnic groups who are vaccinated. Given the misinformation out there, what message would you send to unvaccinated Black residents when they hear those numbers? Finally, we know that public health officials are hoping for people to get the flu vaccine this year. How is the county working to balance campaigns for people to get not only the COVID-19 shot, but also the flu vaccine? Thank you.
Yeah, thanks, Ron. So yeah, let me start with flu. Obviously, super important that we get our flu vaccinations, and this is the time where we're starting to vaccinate. There'll be many sites where we're going to be offering both flu and COVID for those who haven't yet gotten a COVID vaccine or maybe needing a booster. And you know, the guidance right now supports that you can get both of those vaccinations at the same time. For those people who don't want to get both of those vaccinations at the same time, depending on where you fall in terms of eligibility for boosters, we would encourage those not yet eligible to go ahead now. You can get your flu shots all across the county already. Go ahead and do that. Obviously, last year we did much better with people going in and getting flu vaccination, so we're hoping we'll see the same this year. Again, everything we can do to protect ourselves from transmission of flu means that there will be less people that will need health care. And for those people who unfortunately would get flu and COVID at the same time, obviously getting vaccinated reduces your chances of that happening. So we're encouraging and promoting flu vaccinations. And as always, our teams will continue with the flu vaccine campaigns that we have among some of our highest risk residents. So, you know, I think it's important. It's not we're going to do one or the other. We're going to do both. Super high priority, obviously, to get everyone vaccinated for COVID. We're living through a deadly pandemic, but at the same time, we're going to be reminding people to come in and get their flu vaccination as well. In terms of sort of the devastating numbers around hospitalizations for Black residents that are unvaccinated. I mean, the numbers are kind of devastating for everybody who's unvaccinated because, as you can see on the trend lines, the risks are just so much smaller for people who are vaccinated. But it's deeply troubling to see the impact of, you know, sort of decades of institutional racism, the lack of appropriate resources and opportunities for people to be healthy in many of our communities of color, which has created, you know, in part, one of the reasons why we see the gap. People who have underlying health conditions are at much greater risk, as we've noted since the beginning of the pandemic, for a serious or severe outcome if they do get COVID. And if you look across the board at residents in LA County and you look at different groups of residents by race and ethnicity, you will note immediately that Black residents in LA County and really across the United States are much more likely to have many of the underlying health conditions that put them at much higher risk for COVID, which helps explain why they then end up in the hospital at higher rates. And obviously, I mean, the first message for all of us is we have to address the root causes of these inequities, and they play out in ugly ways every day, and they're playing out in the data we're seeing around COVID. So let's not forget that really important work to really address, in this case, systemic racism, the lack of opportunities and resources in some of our communities that are essential for people being well. And let's also make sure at the same time that we're focused on the problem in front of us, which is making sure people understand just how protective these vaccines are, particularly for people at highest risk for serious illness. And the same will hold true now that we're going to be offering a booster. So the boosters really are appropriate at this point for people that have been designated by CDC and the FDA. But high on that priority list are people with serious underlying health conditions. So if you haven't yet gotten your first dose, this would be the time before we get into particularly the fall and the winter months when we all lived through a devastating surge last year. But also would put you then, sort of entering into the next few months with more protection than you have if you remain unvaccinated. And the place where this virus is taking hold, unfortunately, is among unvaccinated people. And then last, in terms of, are we going to be opening up mega points or mega sites for distributing vaccines? Our plan right now is to, really use the capacity we already have in the system. I indicated earlier, we think it's pretty easy for us to be able to administer 130,000 doses a day through the existing sites, with the existing sites amping up their own capacity without opening up those handful of mega sites we needed to have last year when we started, both in December and then earlier this year. I mean, we don't have the same situation this time. When we started administering doses, we didn't have 1,300 permanent vaccination clinics across the county. We didn't have 400 mobile teams. As soon as boosters are approved, all of our mobile teams will be offering first doses, second doses, and boosters. So again, we have a lot of capacity right now. And of course, everybody will need to add staffing and increase their hours of operation, perhaps, so that we can meet the increased demand. But in our surveys of the sites that are currently vaccinating, many of the sites have already told us that they have a lot of capacity to expand very quickly to meet demand. So I think we're going to be able to do it with the expanded network. Thanks for those questions. We'll take the next questions.
And that'll come from Benjamin Gottlieb from KCRW.
Yes, thank you so much. Thank you, Dr. Ferrer, for taking my question. I wanted to ask you about vaccine mandates and verification across LA County. There is a lot of concern among members of the business community, especially at bars, breweries, and wineries, that they might be unfairly targeted in this first rollout of vaccine mandates. Can you first explain why restaurants are not included? And secondly, can you explain how the Department of Public Health will enforce these new rules? What sort of enforcement mechanism will be employed? Thank you.
Yeah, thanks so much. And first, I do want to thank the business community, and I want to thank our bars, breweries, wineries, nightclubs, and lounges. In general, we've heard a lot of support, and I want to reassure everyone, as we have throughout, is we issue very few citations. Given the number of businesses that we inspect, the number of businesses we provide technical assistance to, the number of businesses that operate across the county, we issue very, very few citations. And those really are for places that are flagrantly defying over time health officer orders. Most of the sites we visit are welcome our assistance in coming into compliance. We often spend the first couple of weeks, whenever a new health officer order goes into effect, visiting sites, not to issue citations, but to help make sure people have good information. We hold telebriefings, we address individual concerns. And as you all know, there have been times where we have issued additional guidance to make sure that we're being as supportive as possible of the implementation challenges. So again, I want to thank ahead of time everybody who's working with us. We have a lot of bars already who have done this on their own and are able to provide a good example of sort of the mechanics of coming into compliance. Our toolkit should be ready and posted next week, which again will give a lot, tomorrow, which will give a lot of information for everybody on sort of the how to do different aspects of the requirements and spell out in greater detail what the options are. But I do want to acknowledge, this isn't, it never has been about sort of a got you kind of a mentality here. We value our partnerships. We want to make this work for everybody. We know we have a shared goal right now of keeping ourselves on the recovery journey and protecting each other. So that's the intent there. I spoke about restaurants last week, but I'll just reiterate, most bars, nightclubs, lounges are higher risk settings than most restaurants. And again, I have to say most because there's always places where things are happening that look very different. But in general, what we've seen, again, because we've been inspecting bars all along, is that bars, it's pretty hard for people to keep a mask on while they're indoors because they're often eating and drinking for much of the time. They often are walking around. Many of these places also, there's entertainment, there's dancing, there's singing. So there's just opportunities for a lot of potential transmission, which is why we consider them one of the highest risk settings. So we're going to work hard. We think this is a good way for us to, again, reduce risk. It also reminds people how effective the vaccines are. And again, it just applies to the indoor parts of bars, lounges, nightclubs, breweries, and wineries. Does not apply to outdoor areas. There's no requirements outside for vaccination verifications. So thanks for those, and I think I got all of that, and we can go on to the next question.
All right, we'll go to Claudia Pesquita with KNX.
Hi. So given what you know right now, do you think high-risk jobs will get boosters? And if so, do you think healthcare workers will get them? Will others get them? And given all the uncertainties with the booster shots right now, and the fact that we don't know whether the state will end up requiring vaccination for students 12 and older, do you have a number in mind, like what you're shooting for in terms of like, we need to meet this much demand weekly for doses? You had talked about the current network being able to ramp up to 200,000 doses a week. So I'm wondering, do you think that'll be enough? And then what would you say to someone who may not end up in one of these eligible groups for boosters and they want to get one anyway, or say they're thinking of mixing and matching, like they got Moderna and they're not eligible, so they decide to get themselves a Pfizer booster?
Yeah, thanks. Let me try to get to all of those. First, I just want to start with the clarification on what our capacity is. Our capacity is 130,000 doses a day. And the total number of people who will be eligible in the broadest brush could be 1 million, because that's the number of people who got 2 doses of the vaccine as of April 1st. And we now know that it isn't going to be everybody who had 2 doses of the vaccine. It's going to be a subset of that. I've already noted that there's about 420,000 people 65 and older who are going to be eligible, who've received 2 doses of Pfizer before April 1st. So, but with capacity to be at 130,000 doses a day, we ought not to have a capacity issue, and it shouldn't take us that long. I think what we're preparing for is making sure it's pretty easy for folks. So we'll be sending out information. For example, we have a transportation service that is available to help take people to get their vaccines. So that will be that's available now for people who need their first dose or their second dose. It'll be available for people who need their third dose and are eligible. We also have homebound services and support. Those will be available for people who need third doses as well. Most of those people are, of course, 65 and older. And we have targeted efforts, obviously, at skilled nursing facilities and long-term care facilities, working with the long-term care pharmacy partners to make sure that we can, in fact, get to those sites within a few weeks and get everybody who's eligible vaccinated. I want to note at the skilled nursing facilities, most of the residents have received Moderna. They did not receive Pfizer. I want to say it's almost 90% of the residents who were vaccinated early on were vaccinated with Moderna. So again, they'll be in that group that will need to wait, which is probably a good question about, what should you do if you don't end up in the eligible group? I don't know where CDC will land. I do know that there are lots of people who are already included in what the ACIP voted on today, but we'll need to wait to get that final recommendation. But if you're not in that group, I always say this, if for some reason you think it's really important that you get a booster, please talk to your primary care doctor about what your concerns are. And whether or not you're going to end up being in that category of people who are at risk for serious illness, because that category is going to be there for people 18 and older. And the best place to get advice about whether or not you fall into that category is obviously going to be from somebody who helps take care of you right now. If you're somebody who meets the eligibility criteria, but you were vaccinated with either Moderna or Johnson & Johnson, I can definitely relate to the concern of wondering, should you go ahead and mix and match? I showed a little bit of the data that CDC was using that, demonstrates that those people who received the Moderna vaccine actually are still, it looks like, those vaccines are holding up a little bit better than the Pfizer vaccine. So I would urge people to go ahead and wait until the FDA reviews all of the data that has been turned in by Moderna, that they're getting from scientists and researchers across this country and others, because there's no need to go in and get the booster early. I mean, it doesn't really necessarily advantage you either. If in fact the timing of when you get the boosters is helpful in making sure that you're going to continue to have a strong response for months to come. So I would urge people to wait, let the scientific community to do what they've been doing, review all of the data and make determinations based on the science. And the same thing for those folks who received the Johnson & Johnson vaccine, which, as all of you remember, was rolled out later as well. So we need to get those studies in. We need to collect that information, find out exactly when it would be helpful, if it will be helpful for people to receive a booster dose of Johnson & Johnson. And everybody has seen that Johnson & Johnson has also turned in data that they've been collecting about the need from their perspective to go ahead and do that. For them, it would be a second dose. But, we're lucky in this country that we've got these scientific committees that they're independent, they do a great review, they're well qualified to do that review. And I would just urge everyone to wait until we hear back from them and not to go ahead and do the mix and match unless that's in the guidance. So we can go on to the next question.
Okay, and so probably have to be our last one. We'll go to Sylvia Alvarez with Univision.
Yes, hi. Thank you, Dr. Ferrer, for taking my question. What is the current situation in hospital capacity in LA County because of COVID-19 patients? We've been getting calls regarding some people being turned away because they're dealing with COVID patients. What options do people have if they are turned away because there's not enough resources?
Yeah, it's an important question, and I'm a little bit surprised. Hospitalizations are way down in LA County, down by 50%. And that doesn't mean that there isn't a situation in one particular hospital in one particular area. But I definitely know that there is not a widespread problem in LA County for people that are seeking healthcare at a hospital setting. There's plenty of capacity with this last surge that we experienced. We call it the summer surge. We never really saw any threats to that capacity. I mean, obviously, every time you have a surge and you start increasing the number of patients that need care because of COVID, you can crowd out particularly care for non-urgent hospital services. So that's always a risk, but that is not what is being experienced at most hospital settings right now in LA County. So I would urge that person to go ahead and work with their provider about finding an alternative location if they're seeking hospital care. And certainly feel free to call us back through our media team and identify that hospital, and we can check into the specifics. But we don't know about any hospital that's turning away patients right now. So with that, thanks again. We'll see you next Thursday. We will, continue to provide updates through our announcements and our releases about the plans to go ahead and offer those booster doses. I do want to be clear, as soon as there is approval from CDC in LA County, our residents and our workers will be able to go and get those boosters. I mean, we are ready to move once we get that approval from CDC. We do need that approval. It's part of the provider agreement to be a licensed vaccinator for COVID. So we do have to wait until we get that final approval from CDC. But at that point, we'll be ready to go here in LA County. So thanks, everyone.
Great. Thank you all for joining us, and we'll begin our remarks in Spanish in about 5 minutes. Hi, Monica. You set to begin?
I'm sorry, I was in mute.
Okay.
I'm ready.
All right, give me 1 second. Okay, you're all set to go.
Thank you so much, team. Gracias por acompañarnos en la sesión informativa de hoy. Esta tarde hablaremos sobre las tendencias de casos, hospitalizaciones y muertes por estado de vacunación, por raza, etnia y grupo de edad. Proporcionaremos una actualización sobre nuestros datos de variantes, revisaremos nuestro progreso con la vacunación, incluso geográficamente, y compartiremos los datos más recientes sobre casos, brotes y vacunas en escuelas y niños en edad escolar. También compartiremos información sobre la eficacia de la vacuna y nuestros planes para brindar vacunas de refuerzo a los residentes y trabajadores que aún están en los grupos aprobados. First slide, please. Nos entristece informar hoy 32 muertes adicionales. Al menos 27 de las personas que murieron tenían problemas de salud subyacentes. Esto eleva el número total de muertes a 25.942 en el condado de Los Ángeles. Extendemos nuestro más sentido pésame a todos los que están de duelo por la pérdida de un ser querido, un amigo o un compañero de trabajo y los mantenemos en nuestros pensamientos y oraciones. Estamos informando 1.900 casos nuevos hoy, lo que eleva el número total de casos en el condado de Los Ángeles a 1.449.923. A la fecha se han realizado pruebas a más de 8,54 millones de personas y sus resultados se han informado al condado de Los Ángeles. Nuestra tasa de casos positivos con base en la prueba diaria es de 1,52%, una disminución de un punto porcentual con respecto a la tasa del mismo día de la semana pasada de 1,63%. Nuestra tasa de casos promedio diaria con un retraso de 3 días es ahora de 12,3 casos por cada 100,000 personas, una disminución de la tasa de casos con un retraso de 3 días de la semana pasada de 15 casos por 100,000. Actualmente hay 991 personas hospitalizadas con COVID-19, una disminución de 165 personas durante la semana pasada. Nos sentimos aliviados de que las hospitalizaciones hayan caído por debajo de 1,000 por primera vez desde julio. Actualmente hay 250 investigaciones abiertas en entornos residenciales colectivos y en entornos no residenciales con al menos un caso confirmado de COVID-19. Next slide, please. Para evaluar el riesgo de COVID en el condado de Los Ángeles, usamos los indicadores y umbrales de los CDC para categorizar el contagio comunitario de COVID-19. Observará que este marco utiliza una tasa de casos acumulada de 7 días, es decir, el número de casos por cada 100,000 durante la semana pasada, en lugar de una tasa de casos diaria. El contagio en el condado de Los Ángeles ha disminuido a nivel sustancial, con nuestra tasa acumulada de casos de 7 días, ahora de cerca de 86 casos nuevos por cada 100,000 residentes. Next slide, please. Este gráfico muestra las tendencias de casos, hospitalizaciones y muertes en nuestro condado desde el comienzo de la pandemia al 15 de septiembre de este año. Tenga en cuenta que estos datos se basan en fechas de episodios y están a la saga de la información utilizada para calcular nuestras tasas diarias de casos. En general, continuamos viendo una tendencia a la baja en los casos, hospitalizaciones y muertes. Y aunque los datos aquí se detienen el 15 de septiembre, los datos informados desde entonces continúan con una tendencia a la baja, lo que brinda cierta tranquilidad de que las tasas de vacunación más altas y las precauciones de seguridad en las celebraciones del Día del Trabajo evitaron el aumento habitual de casos que experimentamos después de los días festivos. El 15 de septiembre Nuestro promedio de casos de 7 días fue de 1.476, el más bajo desde el 14 de julio. Mientras tanto, las hospitalizaciones han disminuido un 17% con respecto a las cifras de la última semana y después de un largo estancamiento, las muertes también han disminuido en un 42% con respecto a la semana anterior. No obstante, al 15 de septiembre todavía estábamos viendo casi 2 docenas de muertes por día y estas pérdidas que se pueden evitar no son menos dolorosas por ser menos numerosas. Next slide, please. Continuamos rastreando los resultados entre personas completamente vacunadas para comprender la efectividad de nuestras vacunas. Esta diapositiva muestra los números de casos, hospitalizaciones y muertes entre los completamente vacunados en un diagrama esquemático a escala. El gran recuadro verde representa los más de 5,4 millones de residentes que ahora están completamente vacunados. El pequeño recuadro violeta en la esquina inferior izquierda de este recuadro verde representa a las 52.140 personas completamente vacunadas que dieron positivo por COVID al 21 de septiembre de 2021. Pueden notar que este es un salto más grande de lo habitual en una semana. Esto se debe a que esta semana estamos incluyendo en esta cifra a 1.807 supuestas reinfecciones entre el 1 de mayo y el 18 de septiembre. En el pasado, estos casos no se incluyeron porque no estaba claro si estos casos representaban nuevas infecciones. La definición aceptada ahora incluye reinfecciones que ocurren al menos 90 días después de una infección previa. En total, han dado positivo menos del 1% o el 0,9% de las personas totalmente vacunadas en el condado de Los Ángeles. De los que dieron positivo, 1.732 fueron hospitalizados en comparación con 1.359 la semana anterior. Esto se traduce en que el 0,03% de todas las personas completamente vacunadas deben ser hospitalizadas. Las muertes en este grupo durante este lapso también aumentaron de 199 a 229, lo que se traduce en un 0,004% de muertes entre las personas completamente vacunadas. En estos pequeños aumentos vemos la realidad de que las vacunas no brindan una protección de 100% contra las infecciones. A medida que más personas completamente vacunadas están expuestas al virus, es probable que se infecten más personas completamente vacunadas. Sin embargo, lo que también vemos en estos números es el hecho de que las personas completamente vacunadas continúan estando extraordinariamente bien protegidas de la hospitalización y es muy poco probable que mueran por COVID. Next slide, please. Delta sigue predominando entre las muestras secuenciadas por nuestro laboratorio de salud pública, que comprende el 100% de todas las variantes identificadas recientemente entre esas muestras. Aunque los CDC no consideran que las variantes de Mu o Lambda sean variantes preocupantes, la Organización Mundial de la Salud las identifica como variantes de interés debido a su participación en un contagio comunitario significativo o en múltiples brotes de COVID-19 en varios países. Por lo tanto, continuamos recopilando datos sobre la distribución de estas variantes entre muestras nuevas e históricas. Esta semana informamos de 10 variantes de Mu recientemente identificadas a partir de muestras tomadas previamente en residentes del condado de Los Ángeles para un total de 250 casos vinculados a esta variante. Solo 5 de los casos de Mu identificados se presentaron después del 15 de agosto de este año. No hemos identificado ninguna nueva variante de Lambda en la última semana, por lo que la cantidad total de casos de Lambda identificados continúa estable en 28 casos. Continuaremos dando actualizaciones periódicas sobre las tendencias de variantes entre los residentes del condado de Los Ángeles. Next slide, please. Ahora veremos diapositivas que muestran los resultados por estado de vacunación, por raza y origen étnico, así como por grupo de edad, que ahora incluye los grupos de edad pediátrica. En todas estas diapositivas, los grupos no vacunados están representados por líneas de puntos, mientras que los grupos vacunados están representados por líneas continuas. Esta primera diapositiva muestra que las tasas de casos continúan disminuyendo entre todos los grupos raciales y étnicos no vacunados y vacunados, con las tasas más altas aún entre los residentes latinos y afroamericanos no vacunados, indicados por las líneas de puntos grises y azules. Next slide, please. Al observar los casos por grupo de edad, vemos que las tasas de casos más altas se encuentran entre los adolescentes no vacunados de 12 a 17 años, representados por las líneas de punto de color turquesa, mientras que los miembros vacunados de este grupo tienen las tasas de casos más bajas, lo que indica que la vacuna es extremadamente protectora contra la infección en los adolescentes. Las segundas tasas de casos más altas se encuentran entre los adultos jóvenes no vacunados de 18 a 49 años, en la línea punteada de color púrpura, y los adultos no vacunados de 50 años o más, en la línea amarilla punteada. De todos los grupos no vacunados, las tasas de casos más bajas se encuentran entre los niños de 0 a 11 años, aquí representados por la línea verde punteada. Debido a que este grupo de edad sigue sin estar aprobado para recibir la vacuna, todos, por supuesto, no están vacunados. Observará que la tasa de casos entre los jóvenes de 12 a 17 años no vacunados alcanzó su punto máximo a mediados de agosto, aproximadamente cuando reabrieron la mayoría de los distritos escolares del condado de Los Ángeles. Desde entonces, las tasas de casos en este grupo han disminuido, siguiendo las tendencias en las poblaciones adultas y afirmando que la escuela es de hecho el lugar relativamente más seguro para los niños de esta edad. Next slide, please. Mientras ahora las tasas de hospitalización por raza y etnia, vemos una disminución general en las hospitalizaciones entre todos los grupos no vacunados, con las hospitalizaciones aún más altas entre los residentes afroamericanos no vacunados, representados por la línea azul punteada, seguidos por los residentes blancos y latinos, representados por las líneas punteadas rojas y grises, respectivamente. Si bien las tasas de hospitalización siguen siendo mucho más bajas entre las personas vacunadas de todos los grupos raciales y étnicos, los residentes vacunados con más probabilidades de ser hospitalizados son los residentes afroamericanos, representados aquí por la línea azul continua. Ellos tienen 3 veces menos probabilidades de ser hospitalizados que sus contrapartes no vacunadas, mientras que el riesgo para los residentes latinos y blancos vacunados, representados por las líneas sólidas de color gris y rojo, es de 5 a 6 veces menor que el de sus homólogos vacunados. Una larga historia de acceso inadecuado a los recursos esenciales que apoyan una salud óptima ha dado como resultado que los residentes afroamericanos en todo el condado de Los Ángeles y el país experimenten tasas más altas de enfermedades que los ponen en un riesgo elevado de enfermedad grave por COVID. Nuestras líneas de tendencia validan esta deplorable realidad, que continúa contribuyendo a tasas más altas de hospitalizaciones y muertes por COVID entre los residentes afroamericanos. Next slide, please. Sigue habiendo muchas variaciones por grupos de edad con respecto a la presencia de enfermedades graves por COVID. En esta diapositiva que muestra las tasas de hospitalización por grupo de edad, vemos que si bien las hospitalizaciones están disminuyendo entre los adultos mayores de 50 años no vacunados, representados aquí por la línea amarilla punteada, este grupo sigue teniendo el mayor riesgo de hospitalización, seguido de los adultos no vacunados de 18 a 49 años, representados por la línea punteada de color púrpura. Mientras tanto, la hospitalización es tan poco probable entre adultos, niños y adolescentes vacunados que las líneas de tendencia que lo representan aquí se mezclan en la parte inferior de este gráfico. Next slide, please. Presentamos datos sobre muertes con un retraso de 3 semanas debido a las demoras en la recepción de informes de muertes. Como puede ver, a principios de septiembre, las muertes entre los residentes no vacunados de todos los grupos raciales y étnicos se estabilizaron, mientras que las tasas de mortalidad entre las personas vacunadas se mantuvieron bajas. En particular, esta es la segunda semana consecutiva en la que estamos viendo las tasas de mortalidad más altas en residentes blancos no vacunados, representadas aquí por la línea roja punteada. En el pasado, en general, hemos visto que las tasas de muerte por COVID bajan entre 5 y 6 semanas después de las tasas de casos. A finales de julio, las tasas de muerte alcanzaron su punto máximo en los residentes afroamericanos y a principios y mediados de agosto en otros grupos. Por lo tanto, anticipamos que a fines de septiembre nuestras tasas de mortalidad seguirán siendo altas entre los residentes latinos, blancos y asiáticos no vacunados. Next slide, please. Debido a que las muertes son muy pocas y espaciadas entre los niños, solo presentamos las tasas de mortalidad de adultos en este gráfico. Como puede ver, los adultos mayores de 50 años no vacunados, representados por la línea amarilla punteada, tienen el mayor riesgo de muerte con un riesgo 18 veces mayor que el de sus homólogos vacunados, representados en la línea amarilla continua. Next slide, please. Aunque los casos, las hospitalizaciones y las muertes están disminuyendo, nos mantenemos enfocados en aumentar nuestras tasas de vacunación para evitar ciclos continuos de picos de COVID-19. Al 19 de septiembre, el 92% de los residentes del condado de Los Ángeles de 65 años o más habían recibido al menos una dosis de la vacuna, al igual que el 78% de los residentes de 16 años o más y el 77% de los residentes de 12 años o más. El 68% de los residentes de 12 años o más han sido completamente vacunados. El 66% de los adolescentes del condado de Los Ángeles entre las edades de 12 y 17 recibieron al menos una dosis y el 57% está completamente vacunado. De todos nuestros casi 10,3 millones de residentes del condado de Los Ángeles, incluidos a aquellos que aún no están en los grupos aprobados para recibir la vacuna, el 66% ha recibido al menos una dosis y el 59% está completamente vacunado. En todo el condado, los proveedores del condado de Los Ángeles han administrado más de 80,000 terceras dosis. Next slide, please. Aunque todavía tenemos un largo camino por recorrer antes de que toda la comunidad esté vacunada, no queremos perder de vista lo lejos que hemos llegado durante este verano. En el lado izquierdo de la diapositiva verá un mapa del condado de Los Ángeles que muestra el porcentaje de personas vacunadas en las ciudades y comunidades de todo el condado. El sombreado verde más oscuro representa las comunidades donde el 75% o más de las personas han recibido al menos una dosis de la vacuna, mientras que el sombreado marrón más oscuro representa las comunidades donde el 15% o menos de las personas han sido vacunadas. En las áreas marcadas con un círculo rojo es donde hemos visto los aumentos más dramáticos en las tasas de vacunación al 19 de septiembre e incluyen comunidades en la parte sur, este y noreste del condado, donde se ha logrado un enorme progreso en la vacunación de las personas. Y si bien estamos complacidos con el progreso y agradecidos por los esfuerzos para mejorar el acceso a las vacunas, hay áreas donde nuestras tasas aún están muy por debajo de donde deben estar en la parte norte del condado. Next slide, please. Les mostramos esta diapositiva todas las semanas y desafortunadamente muy poco ha cambiado este mes pasado. Cuando estos números permanecen bajos es simplemente porque no estamos viendo suficientes personas nuevas yendo a recibir las primeras dosis de la vacuna lo suficientemente rápido, lo que significa que no estamos aumentando nuestros niveles de inmunidad comunitaria al nivel donde deberían estar para evitar futuros picos. Next slide, please. Seguimos ofreciendo vacunas en más de 1.300 sitios fijos en todo el condado y mediante el despliegue de más de 400 equipos móviles de vacunación cada semana. Sin embargo, como puede ver en este gráfico, la cantidad de personas que se vacunan cada semana está disminuyendo. Entre el 13 y el 19 de septiembre administramos alrededor de 42,000 dosis en toda la red del condado. Y aunque este número podría aumentar en unos pocos miles una vez que se completen todos los informes, indica una desaceleración sostenida en nuestro progreso de vacunación. No todas las personas que están en los grupos aprobados para recibir una vacuna van a vacunarse. Y como hemos aprendido de otros entornos, cuando muchas personas en un área no están vacunadas, otras medidas de salud pública, como los requisitos de uso de mascarilla y vacunación, se vuelven particularmente importantes para reducir los peores resultados de la infección por COVID y la mayor probabilidad de nuevas variantes de preocupación. Next slide, please. Si bien no estamos donde debemos estar a medida que nos acercamos al otoño, el progreso que se ha logrado en la reducción de la propagación comunitaria también afecta el contagio en las escuelas, con una menor propagación comunitaria correlacionada directamente con menos casos que se presentan en las escuelas. En las próximas diapositivas presentaremos información de nuestras escuelas de kinder a grado 12. También queremos señalar que, con suerte, para el fin del día de mañana o el lunes por la mañana, el tablero de la escuela con mapas interactivos o tablas de resumen debería estar en vivo y se podrá acceder desde nuestra página principal de datos en www.ph.la.county.gov/media/coronavirus/data. Esta diapositiva verá casos de personal y estudiantes y contactos cercanos representados por líneas de tendencia. La mayoría de los casos en las escuelas se diagnostican mediante un examen de rutina de casos asintomáticos que identifica a muchas personas infectadas que normalmente no serían detectadas. Las líneas de tonos rosados representan casos, mientras que las líneas en tonos de verde representan contactos cercanos. Los tonos más oscuros representan los datos de los estudiantes, mientras que los tonos más claros representan los datos del personal. Tengan en cuenta que debido a que la cantidad de contactos cercanos de los estudiantes es mucho más alta que las otras métricas en esta diapositiva, se trazan en un eje y diferente a la derecha de la diapositiva. Cuando las escuelas abrieron en agosto, vimos que semanalmente los casos de estudiantes, aquí representados por la línea rosada oscura, aumentaron de aproximadamente 1.300 a un pico de casi 2.800 casos la semana que terminó, el 22 de agosto. El número de contactos cercanos de estudiantes representados por la línea verde oscuro, es decir, estudiantes identificados como un contacto cercano a un caso confirmado, aumentó en consecuencia a un pico de casi 11,000 a fines de agosto. Desde entonces, tanto los casos de estudiantes como los contactos han disminuido sustancialmente. La semana pasada vimos un poco más de 900 casos de estudiantes y alrededor de 5,000 contactos cercanos de estudiantes. De igual forma, la cantidad de casos entre el personal también ha disminuido semanalmente desde su punto más alto a mediados de agosto. La semana pasada solo vimos 136 casos de personal y 44 contactos cercanos de personal. Atribuimos estas tendencias a la baja al tremendo trabajo hecho por nuestras escuelas, incluidos los administradores, maestros y personal, que han invertido una enorme cantidad de energía y de cuidado para aprender una forma completamente nueva de hacer las cosas este año. También estamos agradecidos con los padres, estudiantes y comunidades escolares en general que han apoyado a sus escuelas en la implementación de múltiples medidas de seguridad que limitan la propagación del virus en las escuelas. Next slide, please. La mayoría de los casos de kinder a grado 12 no están asociados con brotes. Sin embargo, cuando 3 o más casos están vinculados epidemiológicamente, consideramos que estos casos son parte de un brote y dedicamos recursos adicionales para investigar y detener el contagio dentro de la escuela y las redes sociales involucradas. Aunque nuestro número general de casos en las escuelas ha disminuido, nuestro número de brotes ha aumentado ligeramente de 8 brotes la semana que terminó el 11 de septiembre a 11 brotes la semana que terminó el 18 de septiembre. Este patrón probablemente indica que hay muchas más escuelas abiertas durante al menos 2 semanas ahora que a principios de año. La mayoría de nuestros brotes continúan ocurriendo en escuelas primarias y deportes juveniles, aunque la semana pasada también vimos 2 brotes en escuelas intermedias. Y en relación con las más de 3,000 escuelas que están abiertas, estos números siguen siendo impresionantemente bajos. Next slide, please. Esta diapositiva ilustra la cantidad de casos y contactos cercanos relacionados con los brotes que les mostramos en la diapositiva anterior. Puede ver que los casos de estudiantes involucrados en brotes, nuevamente representados en rosado oscuro, alcanzaron su punto máximo la semana que terminó el 11 de septiembre, luego las semanas pasadas disminuyeron aproximadamente a la mitad. El número de contactos cercanos de estudiantes relacionados con brotes, nuevamente representados aquí en verde oscuro, ha fluctuado, pero de nuevo disminuyó casi a la mitad en las últimas 2 semanas. Los casos del personal y los contactos cercanos relacionados con los brotes generalmente han sido de un solo dígito. Si bien la detección temprana en el control de los brotes da como resultado un menor número de casos y contactos involucrados, nos gustaría señalar que los brotes que tuvieron lugar en la última semana aún pueden estar abiertos y bajo investigación y que todavía puede aumentar la cantidad de estudiantes y personal afectados en brotes más recientes representados aquí. Next slide, please. Con tanta información nueva disponible ahora sobre las dosis de refuerzo, nos gustaría compartir algo de información de estudios recientes sobre la efectividad de la vacuna y la justificación de la administración de la vacuna de refuerzo en algunas poblaciones. En los resultados de un estudio publicado la semana pasada, los CDC indicaron que todos los regímenes de vacunas COVID aprobados por la Administración de Alimentos y Medicamentos, FDA por sus siglas en inglés, proporcionaron un nivel muy alto de protección contra las hospitalizaciones de COVID en entornos del mundo real, donde durante el aumento de la variante Delta, la eficacia de la vacuna varió un poco entre las marcas de vacunas. Entre 2 semanas y 4 meses después de la vacunación, las vacunas Moderna redujeron las hospitalizaciones por COVID en un 93%, mientras que la eficacia de la vacuna contra las hospitalizaciones fue del 88% para la vacuna Pfizer y del 71% para la de Johnson Johnson. El cuadro a la derecha muestra los niveles de anticuerpos en adultos sanos vacunados entre 2 y 6 semanas después de recibir la vacuna. Como puede ver, esos niveles de anticuerpos corresponden a estos diferentes niveles de efectividad de la vacuna, con niveles más altos entre los que recibieron la vacuna Moderna, representados a la izquierda, ligeramente más bajos entre los que recibieron la vacuna Pfizer, en el medio y aún más bajos entre los que recibieron la vacuna de Johnson Johnson. También se evaluó la duración de la protección de la vacuna después de 4 meses para quienes recibieron las vacunas Moderna y Pfizer. La duración no se evaluó entre las personas que recibieron las vacunas Johnson Johnson porque el grupo de estudio que había recibido esta vacuna era mucho más pequeño que los otros 2 grupos de estudio. A los 4 meses, Moderna seguía protegiendo mucho mejor, previno el 92% de las hospitalizaciones, mientras que el efecto protector de Pfizer contra las hospitalizaciones había disminuido al 77%. No se publicaron datos sobre la durabilidad de la vacuna Johnson Johnson porque había muy pocos receptores de esta vacuna en el subgrupo para que un análisis de sus datos proporcionara resultados confiables. Mientras tanto, científicos en Israel, donde Pfizer es la vacuna predominante que se administra a los residentes en el Sistema Nacional de Salud del país, publicaron datos en el Diario de Medicina de Nueva Inglaterra la semana pasada detallando los resultados de su programa de vacunación de refuerzo. Su programa, que ha dado prioridad al suministro de dosis de refuerzos a adultos de 60 años o más, mostró que tan solo 12 días después de la vacunación, estos adultos mayores vieron una disminución de 11 veces en las infecciones y una disminución de 20 veces en las enfermedades graves. Next slide, please. Estos datos, junto con la información recibida de Pfizer y otros estudios, justifican la recomendación que ayer hizo la FDA de apoyar la administración de una tercera dosis de refuerzo de la vacuna Pfizer a un subconjunto de personas, incluidos los adultos mayores. La recomendación de ayer indicó que la tercera dosis debe administrarse al menos 6 meses después de la segunda de 2 dosis de la vacuna Pfizer y debe ofrecerse a adultos de 65 años o más, así como a adultos menores de 65 años con alto riesgo de COVID debido a problemas de salud subyacentes y adultos menores de 65 años con alto riesgo institucional u ocupacional. La administración recomendó vacunas de refuerzo para personas menores de 18 años o para personas que recibieron dosis de otras vacunas. Hoy, el Comité Asesor sobre Prácticas de Inmunización de los CDC se reunió y votó sobre quién debería recibir las dosis de refuerzo. Antes de detallar los resultados de su votación, queremos señalar que esta votación no constituye una recomendación de los CDC. Esperamos que el liderazgo de los CDC considere la opinión del comité y haga una recomendación en los próximos días. El comité votó recomendar que la tercera dosis se administre al menos 6 meses después de la última dosis de una serie de Pfizer de 2 dosis en adultos de 65 años o más, residentes de centros de atención a largo plazo, personas de 50 a 64 años con afecciones médicas subyacentes y personas de 18 a 49 años con afecciones médicas subyacentes según el beneficio y el riesgo individuales. Una vez que recibamos la recomendación de la dirección de los CDC, trabajaremos con el Estado y nuestros aliados locales para asegurarnos de que aquellos en los grupos aprobados para recibir el refuerzo, la autorización de uso de emergencia de la FDA pueda recibir su tercera dosis mientras damos prioridad a quienes están en mayor riesgo que, según los CDC, son los residentes mayores y aquellos adultos en riesgo de enfermedad grave por COVID. Next slide, please. El condado de Los Ángeles, en el condado de Los Ángeles, poco más de 1 millón de personas recibieron 2 dosis de Pfizer antes del 1 de abril. 420,000 de estas fueron personas de 65 años o más y muchas otras fueron trabajadores de la salud, personas con riesgo severo de enfermedad grave por COVID. Estamos preparados para administrar refuerzos a todas las personas que necesiten esta dosis una vez que los CDC finalicen la guía de grupos aprobados. Nos gustaría responder algunas preguntas que esperamos que muchas personas tengan mientras nos preparamos para administrar vacunas de refuerzo a ciertas personas. Si bien aún no podemos responder a todas estas preguntas con certeza, ya que aún estamos esperando la orientación de los CDC, anticipamos que los adultos de 65 años o más y los residentes de centros de atención a largo plazo que recibieron 2 dosis de Pfizer antes del 1 de abril estarán en los grupos aprobados y que las personas de 50 a 64 años con afecciones médicas subyacentes y algunas personas de 18 a 49 con afecciones médicas subyacentes también estarán en los grupos aprobados si recibieron sus 2 dosis de Pfizer antes del 1 de abril. También anticipamos que los adultos que están expuestos con frecuencia a este virus debido a que viven en entornos residenciales de alto riesgo, como centros de enfermería especializada, otras instalaciones de atención a largo plazo, centros correccionales y refugios calificarán para recibir las vacunas de refuerzo. La forma más fácil de planificar su refuerzo es concertar una cita en uno de los cientos de sitios que ofrecen vacunas Pfizer. Podrá programar una cita para una dosis de refuerzo utilizando el sistema MyTurn, que debería estar listo mañana para que programe su cita para recibir la dosis de refuerzo o haciendo una cita en una farmacia o clínica que ofrezca vacunas. Para programar una cita usando MyTurn, haga clic en el botón dosis adicionales, certifique que está en los grupos aprobados según los nuevos criterios federales y programe su cita. También hay muchos lugares que no requieren citas. Visite la página de internet vacunatelosangeles.com para encontrar un lugar comunitario cerca a usted donde pueda recibir su vacuna de refuerzo. Todo lo que necesita llevar para recibir su dosis de refuerzo es una prueba de que recibió 2 dosis anteriores de Pfizer, la cual para la mayoría es la tarjeta de vacunación blanca que recibió cuando recibió la vacuna, o una foto de la tarjeta blanca o un registro digital de sus 2 dosis. En muchos lugares se le pedirá que firme un formulario de certificación al momento de recibir su vacuna de refuerzo, el cual indica que cumple con los criterios para recibir la vacuna. Y si está en un grupo aprobado pero recibió otras vacunas diferentes a la vacuna Pfizer, es probable que deba esperar hasta que la FDA revise los datos sobre la necesidad y seguridad de los refuerzos de las vacunas Moderna y Johnson & Johnson. Next slide, please. Sabemos que hay muchas personas que al ver disminuir nuestras tasas de casos, de hospitalizaciones y de muertes, piensan que debemos volver a la normalidad ahora. ¿Por qué seguimos promoviendo las vacunas y viviendo con restricciones como los requisitos de uso de mascarilla e incluso agregando requisitos como los mandatos de vacunación? Estas son preguntas razonables y creemos que para responder a estas inquietudes es útil mirar alguna información sobre lo que está sucediendo en el resto del país. Esta tabla muestra las tasas de casos de 2 semanas y las tasas de mortalidad al 18 de septiembre en 4 partes del país. Aquí en el condado de Los Ángeles, donde el 59% de nuestra población está completamente vacunada y como saben, se requiere el uso de mascarilla para casi todos en ambientes interiores y las vacunas son obligatorias para muchas personas, en la ciudad de Nueva York, donde el 62% de la población está completamente vacunada, las vacunas son obligatorias para comer en interiores, los gimnasios y los lugares de actuación, y en Texas y Florida, donde el 51 y el 56% de la población del estado se ha vacunado por completo y los líderes estatales han prohibido los requisitos de uso de mascarilla y de vacunación en una variedad de entornos. En las 2 semanas anteriores al 18 de septiembre hubo 250 a 280 casos por cada 100,000 personas que vivían en el condado de Los Ángeles y la ciudad de Nueva York, mientras que en Texas y Florida las tasas de casos fueron de 800 por 100,000, aproximadamente 3 veces más altas. Y mire las diferencias en las tasas de mortalidad. Aquí y en la ciudad de Nueva York vimos 4 y 2 muertes por cada 100,000 personas, mientras que Texas vio 12 muertes y Florida vio 22 muertes por 100,000, es decir, de 3 a 5 veces más que en el condado de Los Ángeles. Las diferentes tasas de casos y muertes no solo están allí, son producto de las acciones colectivas que tomamos. Las empresas y las personas que viven en diferentes comunidades cambian estos números cuando adoptan reglas que agregan capas de protección contra el virus mortal. Esto incluye usar mascarillas, hacerse la prueba y vacunarse y aceptar vivir con restricciones que reducen las oportunidades de contagio en entornos de alto riesgo. En lugares donde no se han tomado medidas sensatas para reducir la propagación de este virus, la cepa Delta continúa arruinando el futuro y cobrando vidas a un ritmo acelerado. Como compartimos las curvas de datos cada semana, somos conscientes de que estas curvas, somos conscientes de que estas curvas somos nosotros y nuestra conducta individual y colectiva marca la diferencia en la dirección que toman estas curvas. La realidad es que no hemos vuelto a la normalidad. Quedan demasiadas oportunidades para que el virus se propague y para que surjan nuevas variantes preocupantes. Nuestra historia de pandemias nos ha dicho que progresamos al máximo cuando tomamos medidas activas para reducir la propagación de este virus. Hasta que la propagación comunitaria sea baja y la cobertura de vacunación sea mucho mayor, las estrategias de prevención son esenciales para nuestro bienestar colectivo y recuperación económica. Esperar hasta que la propagación sea alta antes de actuar no refleja la realidad de esta pandemia y la capacidad destructora del virus. Utilicemos las herramientas que tenemos para reducir eficazmente el riesgo de contagio y mantenernos sanos y seguros unos a los otros. Muchas gracias y hasta la próxima.